Hello everyone, today we are going to learn about tracheoesophageal fistula, which is one congenital disorder of gastrointestinal system in child health nursing. So let's start with this introduction. So in introduction it is saying that tracheoesophageal fistula and esophageal atresia are the malformation of digestive system in which esophagus doesn't develop properly, and esophagus is a tube that normally carries food from the mouth to the stomach. So in this condition the organ which will be mainly affected is your trachea and esophagus. Okay, so in this disease condition, the esophagus, which normally carries food from the mouth to the stomach, it will not develop properly, or there will be a malformation in the esophagus tube. So in this disease we are going to see two kind of condition will be there. First one is esophageal atresia, and your second one is esophageal fistula. So let's understand what is the meaning of atresia. Now the atresia, the meaning of atresia is if the esophagus it will not develop properly, or if the esophagus it will be not connected with each other. Now in this picture you can see the proximal part of the esophagus, it is not connected with the distal part of the esophagus. Okay, so there is a gap in between this esophagus tube, right? So this condition is called as atresia. Now the next condition is fistula. The meaning of fistula is it is an abnormal connection between the trachea and the esophagus. If there will be a connection, abnormal connection will be there in between the esophagus and the trachea tube, that condition is called as your fistula. Next is your pathophysiology. In pathophysiology, we are going to discuss how this TEF it is forming inside the baby's digestive system. So the upper part of the esophagus it develops from the retropharyngeal segment, while the lower half will be formed from the gastric segment, and during the 4th week of gestational age one laryngotracheal groove it will form, which is responsible to divide the foregut into two longitudinal tubes, which is further divide into two tubes, that is your trachea and esophagus. So in between that time, if there will be a defective separation will be there, or due to some condition if that two tubes it cannot be formed, in that time that it will lead to develop TEF inside the baby's digestive system. Now in this slide you can see how the esophagus and the trachea it is forming, right? How the foregut it is divided into two different tubes, that is your esophagus, and another one is your trachea. Next, so there are some types of TEF. One by one we will be discuss what are the types of TEF. Okay, so in type 1 you can see there is no connection in between the esophagus tube. Okay, so because there is no connection in between the esophagus tube, they will form two different blind pouch. Okay, so in type 1 there will be no connection in between the esophagus tube. Okay, so next we will see the type 2. In the type 2 what is happening, the proximal segment of the esophagus it is abnormally connected with the trachea, okay, which is called as fistula, and the distal part of the esophagus it is blind. Okay, so this condition have both fistula as well as your atresia. Next is type 3. In type 3, you can see the distal end of the esophagus, it is abnormally connected with the trachea, while the proximal part of the esophagus, it is blind. In type 4, you can see both the esophagus, it is not developed properly, and the proximal as well as your distal end of the esophagus, it is abnormally connected with the trachea. Now the type 5th, type V, it is also called as H type of tracheoesophageal fistula, where the esophagus, it is abnormally connected with the trachea, though it is formed properly. So what are the clinical features which will be pointed to the child if the child is having TEF within them? Okay, so there will be sign and symptoms of severe choking, and the fluid will be returned from the nose and mouth, and cases of cyanosis will be seen inside the baby's body if the baby will have TEF. Okay, there will be excessive secretion of saliva will be there, and cases of abdominal distension will be there, and cases of laryngospasm will be there, and accumulation of saliva will be there, and cases of pneumonia also will be there in severe cases. So what all are the diagnostic evaluation, and how we are going to diagnose the baby if the baby is having TEF? First, it can be diagnosed during the time of antenatal period through the ultrasound, and through the X-ray also it will show that esophagus, it will be filled with air. And next is, if the baby is having TEF, then the nurse, she will attempt to insert one NG tube through the nose to the stomach. But in TF case, that NG tube, it will not go inside the stomach. So that condition also, it will indicate if the baby is having TEF. Next is your management. So this tracheoesophageal fistula can be corrected by surgery, and in this surgery the surgeon, either they will connect that both blind pouch of the esophagus, or they will be going to remove that fistula from the esophagus, or they will be close that fistula depending upon the severity of the disease condition. So in this next slide, you can see where the esophagus, it is rejoined, and where the fistula, it is getting removed from the esophagus. So this was all about TEF. I hope you all understood, and if you have any doubt, you can ask me. Thank you. Hello everyone, today we are going to learn about hernia. So let's see what does it mean by hernia. So hernia is the protrusion of intestine through a weakness in the abdominal muscles. So a hernia, it is a condition in which the internal organ, it will protrude through the wall of the abdominal muscle cavity. So in newborns there are many kinds of hernia we can see, and the most common types of hernia which we are going to study today, that is your omphalocele, gastroschisis, and diaphragmatic hernia. And during the time of infancy and childhood, this inguinal and umbilical hernia, it is the most common type of hernia which can be seen in the children. Next is your etiology and risk factors of hernia. So the hernia can be occur if the wall of the abdominal muscles, it cannot hold back the internal organs. Okay, that is the first etiological factors, a defect in the integrity of muscular abdominal wall. And second, if there will be intra abdominal pressure, it will be increased, that is also one of the etiological factor to develop hernia in the children. So the defect in muscular wall, which is one of the etiological factor to develop hernia in the children, it is again divided into two types. First one is reducible and second one is irreducible. So what does it mean by reducible? Reducible means if the internal content, if it can go back to its place through manipulation, that is called as reducible. And while the irreducible means if the protruded abdominal content, it cannot go back to its place through manipulation, that is called as irreducible. So let's start with gastroschisis, and the definition, it is saying that gastroschisis is a congenital anomaly characterized by a defect in the anterior abdominal wall through which the abdominal contents freely protrude. So in gastroschisis, the internal organs of the abdomen, it will be protrude outside of the baby. Okay, so here you can see in this picture the internal organ of the abdomen, that is the large intestine as well as the small intestine, it has came out, right? So this condition is called as gastroschisis. Next, there will be not any overlying sac and the size of the defect is less than 4 centimeters. The abdominal wall defect is located at the junction of the umbilicus and the normal skin and is almost always to the right of the umbilicus. So that protruded organs, which will be seen in the case of gastroschisis, okay, so it will be always less than 4 centimeters and there will be no overlying sac will be there near to the internal organs, okay, and that protruded organ, it will be always present at the right side of the umbilicus. Next is your omphalocele. So the omphalocele, it is saying that it is the another congenital anomaly that involves the umbilical cord itself and the organs remain enclosed in the visceral peritoneum. With omphalocele, the defect is usually much larger than that of gastroschisis. So I told you about gastroschisis, right? That protruded organ, there will be no overlying sac will be there, but in the case of omphalocele, it is the another kind of congenital abnormalities in which the internal organs of the abdomen, it will be coming out along with the umbilical cord itself and there will be a overlying sac will be there, okay, and it is much larger than that of gastroschisis, okay. Next, what all are the risk factors of omphalocele, okay, if the mother will be pregnant less than 20 years, okay, mostly the younger mothers whose age will be less than 20 years, they are more prone to develop this omphalocele and gastroschisis. And next, of course, the folic acid deficiency also, it is the main factors to develop omphalocele and gastroschisis. And if the mother will be consuming alcohol and cocaine during the time of pregnancy, that will be also the most common factors to develop omphalocele and gastroschisis babies among with them, okay. Next, now here you can see in this picture, this is the picture of omphalocele baby and the internal organs which has protruded along with the umbilical cord, and there is one overlying sac is there, right? So this is the picture of omphalocele baby. Next is management, how we are going to manage the omphalocele. First, observe for any associated problems such as chromosomal abnormalities, congenital heart diseases, or any other malformation. So if we will have that case of OMPHALOCELE babies, first we need to observe if the baby is having some another kind of chromosomal abnormalities, or if the baby is having some congenital heart disease with him. Okay, next is we should maintain the IV fluids, and we should cover that OMPHALOCELE with non-sticky dressing to preserve the body heat and moisture, and prophylactic antibiotic should be given preoperatively. And if the OMPHALOCELE it is small or it is medium sized, then it can be treated without any difficulty. Okay. Next is what is the surgical management of OMPHALOCELE. So the OMPHALOCELE can be treated with surgery if that case is very severe. So in surgery, that sac will be covered up with skin graft, and with the help of sutures, that opening it will be closed. Okay, so here you can see in this picture that opening it has closed with skin grafting. So what all are the medical management of gastroschisis? So the gastroschisis should be carefully wrapped in saline so that the intestine doesn't dry out. So before the surgery, we need to cover off that protruded organ along with the saline, so that the protruded organ, that is your intestine, it shouldn't dry out. Okay, so the next is with the help of NG tube, we should remove the air from the intestine, and we should always administer the IV fluids to maintain the electrolyte balance, and we should always monitor the intake and output of that gastroschisis baby, and we should always do rectal examination to dilate that anal opening. Okay, so this all are the medical management of gastroschisis. So the next is surgical management of gastroschisis. So the gastroschisis can be corrected by one device that is called as silo. Okay, so the silo is a long plastic pouch which will be used to treat this gastroschisis. Okay, so the pediatrician, they will put all the internal organs which has protruded inside the silo bag, and the one part of the silo bag, it will be attached above the belly of the baby, and the other end of the silo bag, it will be just hang over the baby, and the gravity, it will allow that internal organs to go through the abdominal cavity with the help of silo. Okay, so here you can see this is the picture of silo, and how that internal organs it has put inside the silo bag, and how slowly it will go inside the baby's belly with the help of gravity. Next is your inguinal hernia. Now the inguinal hernia, it will be mainly seen, or it occurs in the groin region of the baby. So it will be maybe unilateral, either we can see on the both sides of that groin region, or either it will be bilateral. That means it will happen only one side of the groin region. Next is what all are the signs and symptoms we can be seen in the children if the baby is having inguinal hernia. Okay, inguinal hernias in newborns and children result from the weakness in the abdominal wall that's present at birth. Sometimes the hernia may be visible only when an infant is crying. So if the baby will be crying at that time, that inguinal hernia, it can be visible, and during the time of coughing or during the time of straining, during a bowel movement, that time also it will be visible. Diagnostic evaluation, how we are going to diagnose if the baby is having inguinal hernia. So with the help of physical examination, and we can determine whether it is reducible or whether it is irreducible, and with the help of abdominal X-ray and USG, we can diagnose if the baby is having inguinal hernia. So the management, so depending upon the severity of the inguinal hernia, specific treatment will be there according to the child's age and health. Okay, so there are two types of surgery can be performed. First one is open inguinal hernia repair, and second one is laparoscopic repair. So the treatment of the hernia depends on whether it is reducible or irreducible. Okay, so the reducible hernia, as I before told you, if it can be reducible or if it can be go back to its place through manipulation, then surgery is not needed, and if it is irreducible, then it needs emergency care or surgery and urgent treatment, and in the case of strangulated hernia, the baby needs emergency operation. Next is the umbilical hernia, and the umbilical hernia occurs in about 10% of all children, more often in girls than in boys, and frequently occurs in premature infants. So the umbilical hernia, it can be mostly we can find this kind of hernia in premature babies. So what all are the signs and symptoms of umbilical hernia? So this umbilical hernia, it can be seen at the navel of the baby. Here you can see in this picture, right? Some bulge and swelling like structure is there at the navel. Okay, so the swelling, it is noticeable or visible when the baby will be crying. It will be get smaller, and it will be disappear when the baby will be stop crying and when the baby will be relaxed. Okay, and if the physician will be attempt to push the bulge when the child is calm, and if the child will be lying down, it will go easily inside the abdomen. Next is diagnostic evaluation. What are the criteria to diagnose this umbilical hernia? First one is physical examination of umbilical region, and second one is your abdominal X-ray and as well as USG. So the management of umbilical hernia. So generally at about 1 year of age, this hernia, it will disappear by its own. Okay, so all hernias are expected to close by 5 years of age. Hernia becomes bigger with age, is not reducible, or still it is present after 3 years of age. It needs surgical repair. During surgery, the child is placed under anesthesia. A small incision is made in the umbilicus, and the loop of intestine is placed back into the abdominal cavity. Muscles are then sutured back together. Sometimes a piece of meshed material is used to strengthen the area where the muscles are repaired. So usually at the by 1 year of age, that umbilical hernia, it will be disappear, it will go by its own. And if the hernia, it is still visible after 3 years of age and it is not at all reducible, then the child needs surgical repair. Okay, so this was all about the hernias, and I hope you all understood this topic. So if you have any doubt, you can ask me. Thank you.